Hi, my name's Brian Lally. I'm the president-elect of ACRO, and I'm also a radiation oncologist at the Medical University of South Carolina down in Charleston, South Carolina. I'm here today with my favorite radiation oncologist, the person I love talking about lung cancer with, Dr. Stephen Chun from MD Anderson. Steve, can you do me a favor and introduce yourself to everybody here?
Brian, thanks for having me, and you are my favorite president-elect of ACRO. In any event, I'm a radiation oncologist. I practice at the MD Anderson Cancer Center. I'm a little unique as a radiation oncologist here at MD Anderson in that I split my time between one of the integrated academic satellite campuses located in West Houston and the Proton Center. I'm an associate professor of radiation oncology. I treat thoracic and gastrointestinal cancers, although I still see a lot of patients from other disease sites.
Oh, also, I am really impressed with your history with NRG. Can you explain that a little bit too to the audience today?
Yeah, thanks for the question. My history with NRG goes back to about 2013 when I was I was blessed with being offered to participate in what was the RTOG at the time. So before it became NRG, but the RTOG residency training fellowship, where we got introduced to RTOG. We were able to conduct a secondary analysis. I ended up picking something that ended up having a lot of relevance to locally advanced lung cancer, the role of IMRT. And ever since then, I have done my best to promote NRG oncology trial access in the community, particularly in our suburban satellites here at MD Anderson.
Really cool, man. I love hearing that story. Let's get into the bulk of what we want to talk about today. Why don't we kick it off with this easy question? You ready? Tell me a little bit about what you think the history of locally advanced non-small cell lung cancer management has been and how radiation therapy and chemotherapy have evolved over time.
So, one of the reasons I actually really love being in the locally advanced lung cancer space is because of how much progress we've made in the last 30 years. Many people, who know me know that I'm a classical music um, aficionado or enthusiast. And it's hard to believe that Leonard Bernstein, one of the greatest American musicians, he wrote West Side Story, On the Town, other things. He was diagnosed with a locally advanced squamous cell carcinoma of the lung in 1990. He had single agent radiotherapy, basically palliative radiotherapy at Memorial Sloan Kettering, and lived about 9 months after that. There's famous videos and pictures of him smoking a cigarette in one hand with oxygen to the other hand. And that would have been the expectation in the 1990s. And really, thanks to a number of innovations, 3D conformal therapy, IMRT, allowing us to be more precise with radiation, concurrent chemotherapy, um, and now more recently immunotherapy. We've pushed the needle bit by bit, and we've gone from a 9 month life expectancy, probably in the early 90s, to today, what is the majority of patients alive at 2 years, and over half of patients alive probably at the 4 to 5 year mark. And so I think it's a really exciting time to be looking at locally advanced lung cancer. Just 10 years ago when I was a resident, you were lucky if you got anybody to the 5 year mark. And I think you'd agree, Brian, that we commonly get patients to that mark these days. And I think the coming decade, I expect to see even more advances.
Yeah, the treatment has really become a success story for us and what we've been able to accomplish. But let's take that to the next level. You ready? Tell me what you think are some emerging adaptive paradigms that we should be looking out for or considering to integrate into our clinical practice.
So adaptive radiotherapy has been something that's been talked about, as you know, for a long time. I often joke that it's like the Holy Grail or like the Messiah. You always hear of it coming, but then it never comes. And in theory, the gist of it is adapting our radiotherapy based on some sort of advanced imaging, be it a PET scan or CT scan or MRI. And instead of treating large amounts of normal tissue in real time, adapting as a tumor responds and focusing on where you need dose and not treating where you don't need dose, theoretically, that could help us increase cure rates by increasing dose where we need to get it, and also improve the therapeutic ratio by reducing normal tissue exposure to heart, to lungs. There is a huge amount of evidence from people, including yourself, showing that heart doses are not good. We've also known for a long time that lung doses are not good. They cause pneumonitis. They result in worse patient-reported outcomes for patients. And I think in this era where we're trying to push the envelope even further to further prime immune responses, which create greater risk of pneumonitis, we have to do everything possible to minimize that risk of pneumonitis and cardiac injury. And one of the ways that's promising that we should certainly be pursuing is adaptive radiotherapy.
Steve, that's a great point. And I think, I was taught at an early age that if you don't respect the normal tissues, they're going to bite you. And so we're getting better at controlling the disease, but focusing on these normal tissues is critical. When you're in your practice, how do you optimize your IMRT plans for esophageal cardiac constraints? And then let's do those first, and then we'll talk about, lung constraints in another question. Is that okay? Why don't you
Oh,
go
you
with that
bet.
one?
Yeah, you bet. So I know this is crazy, but the one thing I focus on is having the plan be conformal, first and foremost. It's kind of surprising to some people when I say this. There's been a lot of talk over the years over low dose constraints. Let's bring the low dose off of the lungs, and that inevitably forces dose into the heart. I hope it's not too shocking to people that first and foremost, like any other disease site, be it head and neck or brain cancer or anal cancer, I look at lung cancer plans no differently than those plans. Is the plan conforming? Is the high and intermediate dose conforming to my target? As basic as it is, it's surprising to me that because of some historic concerns about low dose bath and mean lung doses, but what I think has emerged not only from RTOGO 617, but also from years of experience from, let's say, Wilms tumor. We irradiate whole lung radiotherapy for Wilms tumor. That's a V5 or a low dose bath of 100%. And there's 40 years of follow up from that. We now have long term follow up of RTOGO 617. This low dose bath doesn't seem to have any meaningful clinical consequence. So I think really the time is to focus on conformity in terms of specific constraints that I use for the heart. One that has emerged that I recently presented at the World Lung Conference in 2023 is maintaining a heart V40, or the amount of heart getting 40 gray less than 20%. I think for esophagus, I still regard it as a structure in series like the spinal cord. I really just try to have the doses conformal as I can there. And if I'm going a prescription dose of, let's say, 60 gray, not having a hot spot of more than 62 or 63 gray, but really I try to have the dosimetrist carve out of the esophagus the best that they can. I don't really believe in mean doses for esophagus.
Steve, that's a great point. Let's switch gears a little bit now and talk about how to minimize pneumonitis, because when we want to focus on giving Imfinzi after chemorads, if they're on prednisone, it's kind of counterproductive, so to speak.
Again, going back to basics, I think we have to think mechanistically about what causes pneumonitis. When we go back to the classic radiobiology data, they irradiated mice, they irradiated, all sorts of animals to understand what is the threshold dose to cause pneumocyte injury. That threshold dose is probably around 20 gray. That's where the classic V20 constraint comes from. That is the constraint that I look at. I am not concerned with mean lung doses. I am not concerned with the V5 or V10. In fact, if I see the V5 or V10 constrained, I will ask the dosimetrist to spread it out, because if it's being constrained, that inevitably is putting a high and intermediate dose over the heart. And we now know from 0617 and a lot of other analyses that is counterproductive. With with the Pacific trial, we know that the rate of severe pneumonitis is probably in the range of 3 to 5%. We also know from RTOG 0617 and other studies, the risk of severe pneumonitis is also from radiation about 3 to 5%, so probably a cumulative risk of about 10%. Again, going back to basics, the fundamental here that I want to stress is the prospective evidence suggests we should make the plan conformal. If I can convey nothing else to the audience, make the plan conformal. Don't make dose spike into the lungs. Don't make it spike into the heart. Treat it like a head and neck or a glioblastoma or any other disease site retreat in the body.
That's great comments, because I think that's really important to stick to the basics. One question I see struggling at my tumor board, or and maybe we don't struggle with it here, but at places where they may not have strong thoracic surgery, it seems like if you do have a good thoracic surgery program, they're talking more about Checkmate 0816. But I've always thought that the Pacific, outcomes were a little bit superior. I'm just curious how you compare those two studies, given at times it may be a little bit of an apples and oranges comparison.
This is absolutely correct. The Pacific trial and the Checkmate 816 trial, as well as other operative trials like AGN, etc., those are entirely different populations than Pacific. Pacific was for patients with medically or technically inoperable non-small cell lung cancer. So these patients were inherently sicker. When you look at Checkmate 816, substantial numbers of patients were early stage lung cancers. They were all operable. We're not talking about N3 disease, multi-station N2. And so inevitably, when you look at the results of Checkmate 816 or AGN or other preoperative chemo immunotherapy trials, the results seem very good compared to Pacific. But as you allude to, this is an apples and orange comparison. Probably if you were to take those patients treated on Checkmate 816 or AGN, you would achieve very good outcomes with chemoradiation followed by immunotherapy as well. We don't know that because we don't have a direct comparison. But what does concern me is that some surgeons are extrapolating these perioperative chemoimmunotherapy trials to say, okay, we've got a completely unresectable case. We're going to convert it to resectability with chemotherapy and immunotherapy. That's concerning because none of these trials were designed to answer that question. Checkmate 816, AGN, they were designed to show if you're going to give preoperative systemic therapy, chemotherapy with immunotherapy is superior to chemotherapy alone. It was not designed to show that for an unresectable case, that chemotherapy and immunotherapy should be used to convert an unresectable case to resectability. So there's a little bit of extrapolation going on there. I don't know where things are going to end up. I think it's an area that we should be actively investigating. But what I don't think is in a patient's interest is a case where a patient's completely unresectable. They're given chemotherapy and immunotherapy. The surgeon goes in and gets positive margins. Now there's a huge surgical bed that has to be treated with radiation. That erodes the therapeutic ratio because instead of well-defined tumor targets, we're now treating the entire tumor bed. We're also treating in the face of previous chemotherapy and immunotherapy, which we essentially know from the Vokes trial that induction chemotherapy results in much worse side effects for patients. And not only that, we have results of the lung art trial suggesting that postoperative radiation, which we've now been forced into, uh, has its set of side effects, particularly cardiac side effects, likely because we're irradiating a much bigger area. So that's my concerns about this extrapolation going on. I would say that, if surgeons want to give it a chance to see if you can downstage something with chemotherapy and immunotherapy, okay, great. But if it's not been downstage, please do not go in there when you know you're going to get a positive margin. That's not doing the patient a favor.
Yeah, I agree with you 100%. But I think that's all I wanted to talk about today. You up for making this a recurrent series?
Oh, anytime.
Okay.
So long as you're happy to have me.
I always happy to talk to you. But I think that's all we got for now. I just want to say thanks for your time, and
You
that's
bet.
it.
Well, thank you, Brian.